Great. So you're going to be hearing today from myself, Nana Khanna, Executive Director of Positive Women's Network USA. You're also going to hear from Arnita Rogers, our fabulous legal fellow from Law Students for Reproductive Justice. I'll introduce Arnita more fully later, but Arnita is really a lot of the flesh behind the report that that you're going to be looking at today. And the report is beautiful. I'm going to repost the link in the chat box so that you can take a look at it. It was really very much a collaborative effort, and this is about a 12-page document that we hope you all will make the time to read, but we're going to highlight the findings from it today. And so the link is in the chat box so that you can click on the report when you are ready to do that. So here's what we're going to talk about on today's webinar. We're going to talk a little bit about the context, why we did this project, what implementation looked like, and particularly why we used a community-based participatory research method, why that was important in terms of sort of guiding the values and vision for the project. We're going to go over some of the key findings, and then we're going to go over some recommendations. And then we'll have time for discussion. And so just starting a little bit with the context, as folks know, we're in this era where we have had Affordable Care Act implementation for going on for a number of years, and it's sort of playing out unevenly in different parts of the country. So while the Affordable Care Act has opened up a lot of opportunity for people living with HIV and folks living with chronic conditions, for example, by eliminating pre-existing condition exclusions, which has opened up a lot of opportunities for people living with HIV to be covered by insurance in a way that we weren't previously. There has been uneven implementation in part because of the state's authority to expand or not expand Medicaid. And so there's a little map here that you can see, kind of where the current status of state Medicaid expansion decisions. And so the orange states on that map, and I know it's a little bit hard to see this, but you can kind of get a general idea. The orange states are the ones that are not expanding Medicaid at this time, which basically means that they are not expanding Medicaid coverage to people of a certain income level, and we'll talk about that in a little bit more detail later. So you have to be extremely low income in order to qualify for Medicaid in these states that are orange. And so we are really seeing, kind of some growing health disparities, disparities in terms of access to care and to services. And then at the same time, we're in an era where, there are a lot of questions about the future of the Ryan White program. So the Ryan White program, which is also discussed and sort of historicized a little bit in the report, has been around for about 25 years in various iterations, providing services, care, medical care, and supportive services to people living with HIV as a payer of last resort. And so the Ryan White program is currently up for reauthorization. It has been for the last couple of years. And because of, concerns about who's in Congress and also wanting to see sort of how the Affordable Care Act will play out most effectively and figure out how Ryan White can wrap most effectively around ACA implementation, the community has sort of said, let's wait to reauthorize Ryan White, hopefully in a better congressional environment, and also once we have a little more data about how ACA implementation is working, what's working well, and where we can really sort of buffer access to care and access to services through the Ryan White program. And so we thought it was important at this moment in time to sort of look at what is actually going on for women living with HIV, a few years into Affordable Care Act implementation, as we're looking at how Ryan White reauthorization is going to be approached over the next several years. We wanted to make sure that we had some clear priorities for women living with HIV. We also know that For the third year in a row, the president's budget proposed consolidating Ryan White Part D into the Part C program. And Ryan White Part D is the only part of Ryan White that has sort of traditionally and historically served women and families and youth impacted by HIV. It wasn't really created for women. Part D was created to prevent us from transmitting HIV to babies, but it has evolved to be a really important resource for women living with HIV. And, as the demographics of the epidemic are shifting, including women aging with HIV now and women being diagnosed at later ages, it has become, it's become very clear that some of the services that Part D is providing continue to be very important, and they're not only important in the context of vertical transmission. They're really important in the context of health care, sexual and reproductive health and rights, and not just for cisgender women, and not just for any women, period. They're actually important for people of all genders and all ages living with HIV. And so in terms of the epidemic, I talked a little bit about the shifts already, but we know that women of color, particularly Black and Latina women in the U.S., are disproportionately impacted by the epidemic. And so if you look at this slide here, you can see, sort of the pie chart on the right is what the percentages of the female population in the U.S. look like. This is data from CDC. And the pie chart on the left is who's being diagnosed with HIV. And so we see a real disparity, so whereas Black women in the U.S. comprise 13% of the population, they comprise 62% of HIV diagnoses. And Latina women comprise about 15% of the U.S. population and 16% of HIV diagnoses. And so we see a real overrepresentation of Black and brown women, especially Black and Latina women, who are affected by HIV. The data on First Nations women, by the way, are, kind of traditionally not that accurate and easy to get, but we also know that Native American women, First Nations women, are disproportionately impacted by the epidemic. This is just a little chart looking at who the ages of women who are being diagnosed with HIV, and I think the one thing I wanted to really highlight here is that we're seeing a lot of women over the age of 45 being diagnosed with HIV in all these different transmission categories. So particularly, when we look at heterosexual contact. And so although many times services are sort of targeted for younger women and women of reproductive age, there's a growing population of women who are older than reproductive age who are living with HIV and being newly diagnosed with HIV. So both aging with HIV and being newly diagnosed with HIV. And so there's a new set of needs and services that we need to be prepared to respond to in this changing environment. And then we also know that as folks are living longer with HIV, there's a whole lot of other stuff going on. So women with HIV have very high rates of trauma, post-traumatic stress disorder. Some studies have shown, one meta-analysis showed that approximately 30% of women living with HIV have been diagnosed with PTSD. Rates of depression are very high. Rates of intimate partner violence, lifetime sexual assault, and other forms of trauma are extremely high, and those have an impact, it's well documented in the literature, on health outcomes themselves, but also on the ability to engage in care. And so this is something that we really need to be thinking about and considering. And we also know that when we're talking about an epidemic that's mostly women who are impacted by poverty, mostly women who are also impacted by racism, those are forms of trauma as well and forms of structural violence. And so our response as an HIV community needs to be prepared to account for sort of all of that. And then we also know that there are some disparities. Disparities are not only in who is acquiring HIV, there are disparities in health outcomes. And so morbidity and mortality especially for Black women living with HIV in the South, there's a real disparity in terms of health outcomes, depending on who you are, where you live, and the access to care you have. And so with that, I'm going to go ahead and talk a little bit about the implementation of the project and what we did. So in 2015, in the summer of 2015, in spring of 2015, we basically recruited 14 women living with HIV as community-based participatory researchers. They were recruited in 7 teams of 2 women each, so in like 7 different geographic regions, and trained in community-based participatory principles, survey design. We partnered with a researcher at Santa Clara University who kind of helped us think through this whole process, delivered some of the training. And then we conducted a series of training webinars for the team and for our staff who were working on the project in collaboration with each other. And also through those webinars, we generated some of the major domains we were going to address through the research project, kind of identified what our key questions were, and worked together to get a better understanding of how to design a survey instrument that would get to our questions. We also provided reading materials, and we had monthly conference calls going on throughout the project. So the whole project went on from about April until really around October or November, when we were looking at the data that had come in. And so we were doing monthly calls with the research team to support them, and also sort of check-in calls as needed. The researchers did receive an honorarium for their time. Their time is valuable. We certainly wish we could have given them more, but they received an honorarium for their time spent engaging in the trainings as well as the project implementation and research. And so this is some of our beautiful researchers. You'll get to hear from a few of them on today's webinar. I know a number of them are on the webinar and are checking in on the chat box. So I just want to highlight we had a team from the Bay Area, Lauren Jones and Cindy Sanchez. We had a team from Baton Rouge, Louisiana, Meta Smith and Sharon DeCour. We had a team from Southern Michigan, Patricia Clark and Deidre Rick. From the Orangeburg area in South Carolina, Veronica Briscoe and Pat Kelly. From the Tampa area in Florida, we had Janet Kitchen and Lapina Reed. From the San Diego area in California, we had Heather Garza and Rachel Motes. And from the Chicago area, we had Ebony Turk and Sharand Adams. And you can see some of their photos here. It was a really incredible, diverse and dynamic team of researchers who were all women openly living with HIV in their communities and really were the thinking behind this project. And so I'm going to go ahead and turn it over to one of our community-based researchers now, Lauren Jones, who's going to talk a little bit about the way that we approach the project, and then we're going to hear from another researcher, Janet Kitchen in Florida, after Lauren speaks.
Good morning. This is Lauren. I'm happy to be talking to you all. I'm going to talk about the section on community-based participatory research. Community-based participatory research is a collaborative approach to research that equitably involves all partners in the research process and recognizes the unique strengths that each brings. CBPR, which is the acronym, begins with a research topic of importance to the community and has the aim of combining knowledge and action for social change to improve community health. That sounds like a very complicated definition, but in reality, it was actually kind of a wonderful process because it does involve both professional people who have degrees in doing research projects. It involves input from community partners and HIV-positive women themselves, which for me was extremely important because, first of all, it is one of the best ways to build self-esteem of HIV-positive women, and also carry through on some of the actual basic strategies that we've insisted on over the years. I myself have been positive for more than 30 years now, and I do believe in the concept that there should be nothing done for us without us. And this project definitely helped implement that goal of us having a voice and a say that everything that happens that concerns our bodies. And it also addresses the concept that we are not just a problem. We are part of the solution. So this was a very important project to be involved in. And some of the basic principles of community-based participatory research are that it recognizes a community as a unit of identity. In other words, as the HIV community, as we're often called, and the AIDS community, we are also a community of women. So that was important, and it does build on the strength and resources within the community. Over the years, many of us have been involved in numerous trainings. We've been in, over the course of at least 25 years of my 30 years of being HIV positive, I can't even count the number of research studies that I've been in. So I'm very familiar with what is generally the process, the need for consent forms, the way questions are asked about how long a research study takes, and that kind of thing. So we do have knowledge in the area, and we as a community of women have also become resources in and of ourselves. It facilitates collaborative, equitable involvement. Again, that goes along with the concept that there should be nothing done for us without us. And it does integrate knowledge and action for the benefit of all partners. We do gain knowledge during this process. I think most of us, when we've been involved in research studies, whether they're clinical research studies or whether they're observational studies or survey studies, have often wondered, who comes up with these questions, how do they come up with that process, and who is actually involved. So this is a way of getting to know that. And it promotes co-learning and empowering process that attends to social inequities. And I do believe that this is one of the very few times when women that are not necessarily highly educated have been able to be involved in a process such as this, and you didn't need to be rich to be involved in this process. So it was a more equitable in terms of social standing and that kind of thing. It is clinical and incremental, and I'm actually going to, let one of the more professional people address that sentence because I don't know that I can give an accurate interpretation of that. But it also addresses health and positive ecological perspectives. And it is definitely thought of in terms of health. This was a survey that basically addresses access to HIV health care. So it does address that. And ecological perspectives, in my interpretation of that would be that it is geographic in the sense of being in California. I have learned that my ecological conditions can be very different than that of someone in Georgia or Mississippi or any part of the Southeast. And it does disseminate findings and knowledge gained to all partners, and that is part of the process that's going on now. So thank you.
Great. Thanks so much, Lauren, for that really fantastic overview of community-based participatory research. I think we're going to hear from Janet Kitchen, another of our researchers now, about what it was like to be trained and be part of this process as a researcher.
Hi, thank you, Nana. Hello, sisters. Happy National HIV Women and Girls. It's actually day 4, so I'm really happy to be on the call. Um, as one of the researchers, it was very exciting to be part of the training. I really didn't know what was, I guess, expected of us, but after going through the process of the training, it was very, very well designed. It was very comprehensive. Dr. McKenzie actually, set forth a guideline and a footprint for us to follow, as well as taking the time out for the women and all researchers that were involved to exchange ideas and actually add some clear substance according to regions in which we lived in, things that we thought were very pertinent and very relevant that should be some of the questions that were highlighted. One of the things I think I found most exciting about it was to have a purpose, as the Sister Lauren says, of for us and by us. And it actually allowed us to get a chance to explain what community-based participatory research was to our sisters when we were doing the surveys. I've been positive now for 11 years, and it's always great to be part of something where we actually have our own words in it so that we actually give voice to what we're doing. The training, again, was very well designed, very thought out, very thorough. It had a lot of validity to it, and the ethics and integrity of the process and the training. I think most of the women and sisters that went through the training can now use this in the future whenever they want to design a survey. The survey actually told us how to design the questions, the strategies on how to go through it, and then going forth through implementation. So all in all, it was a great training. Thank you.
Thank you. Thanks so much, Janet. And Janet is calling in from the Tampa area in Florida. So we're really glad that we were able to have participation from women from all over the country. And so next up, I'm going to introduce a couple more of our fantastic research team members, Ebony Turk from Chicago, Illinois, and Lapina Reed from Tampa, Florida. I think we're going to hear from Ebony first. Ebony's going to talk to us a little bit about the process of collecting data, what that looked like, who data was collected from, and what it was like to actually do the data collection, and some glitches and learnings along the way.
Thanks, Nana. Hi, everybody. I'm so excited to be on with all of you guys today. So a little bit about the data collection. As you can see, we had 180 participants that we recruited from all different points of healthcare delivery systems, including AIDS service organizations, local clinics, social service providers, community-based organizations, as well as support groups. As Nana said, we had the Bay Area, Baton Rouge, Chicago, Orangeburg, South Carolina, San Diego, California, Southern Michigan, and Tampa. And the survey was administered on SurveyMonkey, and we did that from May through July of 2015. The participants that were recruited all received $20 Walmart gift cards, and the researchers, we supported the participants in responding to questions. All of the medical data in the collection was all self-report, no medical records. So, as I just said, the different sites that we recruited people from were support groups, and support groups are pretty easy to recruit from when you're a part of it, which is kind of what makes community-based participatory research so awesome, is that you are kind of getting the research from women in your community, and it's from someone in your community. Clinics and hospitals, there were things around getting permission to recruit from those types of places, and how to get the surveys done, because the survey work was on SurveyMonkey. Community-based organizations, housing agencies, and I put special events because I know we had a camp that was for some HIV positive youth, and we were fortunate enough to be able to recruit some of those young people to do the survey, so different events like that. The way we did the surveys, so some people came, like if you had a support group, we could set up, if you had multiple computers, you could set up multiple computers, and both of the research could be there helping the people in the group do the survey. We had individuals come in, and we individually administered the survey with the ladies. And then if there were problems with some people getting to a site, some people did phone interviews. So they just kind of read the research questions to the women over the phone and recorded their response there. And when they were able to get the consent and all that in person, they did that then. The barriers to administrating the surveys were, of course, travel, because we wanted to do as many of them in person as possible. So travel sometimes was a barrier. Question framing, meaning the way, so we all beforehand, like Lauren just said, we all got together and we decided on the questions we wanted to ask and how we asked them. But sometimes those questions were a little confusing for people, so the question framing was a little bit of a barrier, but to overcome that barrier, it was good to have somebody sitting there, the researcher there, to explain what the question meant. If you were doing the survey in a group, not having enough computers at one time was a barrier, because it would slow you down, because the survey was about 30 to 40 minutes to fill out all of the questions. So not having enough computers if you were doing it in a group. And, of course, Wi-Fi access, because, again, it was on SurveyMonkey. So if you didn't have Wi-Fi, or the Wi-Fi was bad, it wasn't a good connection, then that was challenging to administer the survey. So the lessons we learned from doing this community-based participatory research was hopefully everybody can still hear me. I'm not sure what just happened. But the lessons learned were women living with HIV do care very much about their reproductive health and are willing to travel and take a survey for a small compensation. It wasn't shocking that women cared, but it was shocking that women really wanted their opinions to be heard about reproductive health. I didn't personally realize so many people were having thoughts and issues about their reproductive health. So it was good to know that we were doing something that was really needed in the community. Compensation for their time was appreciated but not needed for some. And for some, it was the reason they participated, because as we heard before, so many women, unfortunately, are living in poverty, and some people have to live in poverty in order to receive medication, which is unfortunate. So the little compensation that we did give them, it was needed, so they were really eager to take the survey to get the gift card. Being connected to the community makes it much easier to recruit. It was no problem for some sites. The site I worked at was no problem for us recruiting, because we are part of the community. We worked in the community, and we were connected to a lot of women who were living with HIV. We also learned that you get better accuracy on the survey if you go over the questions one by one and encourage them to ask questions if they don't understand what the question means or how the question was framed. Some of the women who wanted to do it by themselves, once I went over it after they did it, I would notice that they skipped some questions or something like that. So we would have to go back over it and do it again. So I learned that if I just go over the survey with everybody in the beginning, we wouldn't have that problem. The surveys are complicated to the brightest individuals, so going over them with everyone gathers better data, which is pretty. And that's it for me.
Great. Thank you so much, Ebony. I think you really highlighted, a lot of the factors around data collection and definitely some learnings that we can use to do this better next time. So thank you for that. I want to check if Lapina Reed is able to unmute and on the line. I think Lapina is going to talk to us a little bit about data collection as well. Are you with us? Okay. Lapina may not have been able to join. If you are, Lapina, just check in on the chat box, and we'll come back to you later. But we'll keep it moving in the interest of time for now. We have a number of other researchers who are also logged on to the webinar, and I just want to encourage them again to, if you want to, just check in on the chat box, introduce yourself as a researcher, and we'd love to hear from you also when we get to the discussion and questions that folks might have, because I know that there are so many folks who have a lot of insight about the project, and we thank you all for being part of it. So I'm going to go ahead and turn this next part over to our fabulous HIV Reproductive Justice Legal Fellow, Arnita Rogers. Arnita Rogers has been with PWN since September of last year. She really, jumped in on a project that was kind of underway and has done a fantastic job at looking at the data, analyzing it, really thinking about what it means, and helping to put together a lot of these findings. And so Arnita is going to go through some of the findings for us here, and I'm going to turn the mic over to her.
Okay. Thank you, Nana. That's a really nice intro, and thank you to all of our fabulous researchers for the amazing work that they've done on this project, and for also talking about the value of community-based participatory research. Okay. So, as Nana and Ebony and Lauren and Janet already spoke about the collection of our data, we collected data from around 180 women living with HIV, and with the intention of collecting data that was reflective of the national epidemic. So here you see on this first chart that, I'm sorry, just one moment. Oh, here you see on this first chart that as far as our racial demographics that we collected, they were very close to the national epidemic for two major categories. So for Black women, our survey respondents, there were 67% Black and 16% Caucasian reporting. However, for our respondents that reported their race, ethnicity as Latina, that was slightly lower than the national epidemic. And this is because our survey was collected in English only, and so we only had a few respondents that were able to, and researchers that were able to translate for respondents that were able to take the survey. So that is a lower percentage than what we would like, and that is reflected in our actual data. Our age that we collected for our respondents was closer to the national epidemic as well. So we had about 40%, or slightly over 40% of our women were at reproductive age or under, being 44 and under, and about 60% were above reproductive age. Overall, our mean age was around 47 years old. So we also had data that we collected that was not available for women on the LGBT spectrum. And so we had the majority of our women, as reflected, that we know of in the national epidemic, were 78% were reported as being heterosexual, and 6.1% as being lesbian or gay, and 4.9% as bisexual. So in keeping with the principles of community-based participatory research, we did not have any women, any researchers of trans experience on our researcher team, and so our data is reflective of that. While we did have a few respondents, it is reflective of that. We didn't have a majority of are women, even though we know about the prevalence of HIV for women living with trans experience. So, okay, and also we collected data based on residents being in the southern region and in the non-south region, and we also broke that down by Medicaid expansion states versus non-Medicaid expansion states, because we know that the majority of states that have opted out of the Medicaid expansion are along the southern corridor, and subsequently, and not unsurprisingly, those are the states with some of the highest prevalence of HIV and where we're seeing some of the deepest disparities around health disparities. Okay. So overall, we saw that as we collected data around the income of our women, that women living with HIV are living in poverty, and they're facing severe economic insecurity. Our sample tended to be even lower than women that were in the Ryan White client population. So we'll see here on the first bar chart that almost 90% of the women that reported their income said that they were living below 138% of the federal poverty line.
A presenter has muted the meeting. Your line cannot be unmuted.
About 74% of women said that they were living below 100% of the federal poverty line. So just to give an idea in actual numbers, in 2015, for an individual that would be at 100% of the federal poverty line, that is around a little less than $12,000, and for a family of three, under $20,000. So very stretched income. And so with that very limited income, our respondents also reported that they were supporting others with very limited resources. So 42.4% said that they had dependents in their household, and a significant number of the respondents said that they had children under the age of 18 who they were caring for. It's also significant to note that this was across reproductive age. So these are women that are also, they might be caring for their own children, but they might be also caring for others in their family or in their community, regardless of their reproductive age. All right. And so we also asked information regarding housing. So you can see on this chart here that a significant number of our respondents reported receiving some type of subsidy to maintain their housing, either through Section 8 or HOPWA, which is Housing Opportunities for Persons Living with HIV. And so we can see that advocacy around maintaining and even increasing funding for HOPWA is very significant because so many people are relying on that resource. Additionally, some of our respondents report actually being unstably housed as to the extent of living on the streets or living primarily in shelters over the course of the past year. So we know that maintaining housing funding and supportive housing can be a major barrier to maintaining care, and especially as we see housing prices increase across the country in major metropolitan areas, especially here, places like the Bay Area, housing prices might displace people living with HIV, making it harder for them to access services and care from the places and the providers that they know. Okay, so overall in our data, we found that our respondents majority of them were longtime survivors. So the mean time to diagnosis reported was 16 years. So people have been living with HIV for a number of years. And even a significant number of women have been living with HIV for 20 years or longer, 36%. The majority of women have been living with HIV for 10 years or longer at nearly 77%. Also, as women living with HIV are aging, they're also facing comorbidities and co-occurring conditions. So here are the top three comorbidities that were reported were hypertension at 30%, and hepatitis C at 21.6%, and diabetes at 17.2%. The number of women reporting hepatitis C as a co-occurring condition is very close to the national average, which is reported about 25% of people living with HIV also have the comorbidity or co-occurring condition of hepatitis C. So that's very close to the national average. Okay, and so also the majority of our respondents reported receiving their health care coverage through a public program. You can see that the majority of the women reported being on Medicaid only, but also a significant number of respondents reported receiving both Medicare and Medicaid or Medicare only, or receiving parts of their coverage through the ADAP program and or a combination of ADAP, Medicaid, and Medicare. So it's significant to note that also not reported here on this chart that almost all of our respondents reported receiving some type of services through the Ryan White program. 96% actually reported receiving either services from a Ryan White clinic or a Ryan White-funded community-based organization. Okay, so I think as Ebony was speaking to, our data collection happened from points of entry into the healthcare delivery system. And so here you see that we have our respondents reported a very high level of engagement and care. Almost all, 99.4%, said that they had seen a medical provider for HIV care within the past year. Additionally, 86.4% reported that they were taking medication daily to manage their HIV care, and 79% reported having an undetectable viral load since the time of their last lab results. So this is significantly higher than the national average of women that are living with HIV, who only about 45% of women living with HIV are reported to be in care, and the level of viral suppression is around 30%. So we're seeing that even as we're going to examine some of the barriers to care, women are engaging and committed to remaining in care and taking care of themselves as they're juggling multiple responsibilities and multiple family responsibilities and managing their care. And then finally, only 6% reported not taking their HIV medication. So we also asked a number of questions to examine the quality of care that the women were receiving. Some of our major findings came from the areas of access to sexual and reproductive health care and mental health services, which I'll speak to in just a slide or two. So as far as accessing sexual and reproductive health care, overall, providers are generally doing a fairly decent job at screening women living with HIV for cervical cancer, for which they are at a higher risk. You'll see here that 82.9% of women of reproductive age received a pap smear within the past 3 years. However, that number was lower for women over reproductive age, who about 75% of those women reported receiving a pap smear within the past 3 years. So it's important to note that while those numbers are high, they should be high for women of reproductive age and women above reproductive age, because the quality of care and the continuum of care needs to be consistent across the lifespan of women living with HIV. However, when it gets to examining the full conferral of sexual and reproductive health care for women living with HIV, we are continuing to see a persistent communication breakdown between women and providers. So we're reporting that only about 40% of women of reproductive age have been asked if they needed birth control. Additionally, only about 40% of women of reproductive age have been asked if they wanted to get pregnant. Also, this is not of reproductive age or above, but only about roughly 40% of participants had not been told that that achieving viral suppression would dramatically reduce their risk of transmission. Despite our scientific advances that can provide sexual and reproductive rights and healthcare options for living with HIV, we're still seeing that providers are not counseling and encouraging women to seek their full options or fertility choices or family planning for which they are entitled to. Okay. So mental health. We were listening to a very good webinar yesterday by the Well Project that talked about some of the devastating disparities around mental health and women living with HIV. So women living with HIV are more likely to suffer from PTSD and depression in the data collected by our respondents reflected that. So 17% of the women, 17% of our respondents reported that they had been diagnosed with PTSD. And alarmingly, about 65% also said that they had been diagnosed with depression. So these disparities are very alarming, and we also noted that in the wake of these disparities that the women in our survey also were seeking support. So nearly 2/3 of the respondents reported that they would like to see someone for counseling or therapy. But however, of those, 41% were unable to access therapy due to some barrier, either being to cost, to lack of available services in their areas, or a wait list for services in their area. So some additional barriers to care that we examined. So as mentioned earlier, transportation was a major barrier to care reported in many different ways for women living with HIV in our survey. So 50% of the respondents who had missed a medical appointment in the past year cited a lack of transportation as the reason for missing that appointment. And so nearly a quarter of the respondents that had missed filling a prescription for HIV medications in the past year also cited a lack of transportation as that reason. So we can see that as we talked about the rising cost of housing and getting further and further away from providers and access is an issue, that this is a major barrier that should be addressed. Even thinking about navigating a public transportation system when you're already sick can even serve as an additional barrier to achieving care. So the data I already spoke about around the number of women living with HIV under the federal poverty line or at 138% of the federal poverty line. This also reflects that this is impacting their ability to receive care by filling their prescriptions. So 15% of respondents who had missed filling a prescription cited the cost of copays as the reason. Additionally, child care served as additional barrier for women seeking care. So 50% of participants who reported needing child care services on site at their medical provider did not receive those services. This is also true as child care services have traditionally been targeted or been reserved for women of reproductive age. But as we saw in our data, that women living with HIV are caring for people through the course of their lives. And so those services may still be required for them to receive care. Okay. So in summary, the snapshot of our data, our participants were severely low income, and in the context of that, of their economic insecurity, they also had significant family responsibilities. Women living with HIV were also dealing with other health challenges, other comorbidities or co-occurring conditions, and having to deal with managing those conditions, but also around the health literacy around managing multiple conditions and accessing care for all of those conditions. We saw overall that the Ryan White system was working for our clients when they were able to access it. Major barriers to achieving care included the rising cost of copays, transportation, and child care at points of service, either medical service or in supportive services that they were seeking. Mental health services and support groups were needed, and women wanted them, and the quality of sexual and reproductive health care was inconsistent, especially as women, especially among women that were aging with HIV. And so we have a few recommendations that are coming directly out of these findings that Nana and I will discuss now.
Great. And so, obviously there's more data in the report as well, and we encourage you to look at the full report, to get a better sense of the data and some of our analysis around why some of these trends are happening. So, particularly around women of all ages having significant family responsibilities and other things like that. There's a lot of analysis in the full report around this. So we're going to talk about a few of our recommendations just briefly, because we do want to have time for questions and discussion. So number one, as this survey process sort of taught us, and I think even as the feedback from the researchers that we heard today is showing us, it's really important that women living with HIV are meaningfully involved in all processes around care, service delivery, thinking about how research and clinical trials are done. And so as we move forward into integrated prevention and care planning, we are definitely concerned that there is no mechanism right now that mandates involvement by the communities that are impacted in these planning processes. And so that is a strong recommendation that we're making, that women living with HIV, reflective of the constituencies being served, are meaningfully involved in these planning processes. That meaningful involvement means more than just having somebody be able to come to a meeting. It also really means representation, leadership, and supporting folks to participate meaningfully. So building capacity of the communities most impacted so that they can participate. And we really encourage Ryan White planning councils, state advisory bodies, and other things, other sorts of entities making decisions about how services will be delivered, including clinics, community-based organizations, to lean on and utilize local networks of people living with HIV as a resource. There is a very exciting resurgence of grassroots leadership by people living with HIV happening all over this country right now. And so Positive Women's Network USA is one resource. There are a lot of other resources at the local level and at the national level, including, Positively Trans, which is a new network forming of trans folks impacted by HIV. There's the Zero Project, which is a network of criminalization survivors. There are lots of different groups at the local and state level as well. And so we really encourage folks to think about engaging with those network bodies. It's very different than engaging with just individuals because networks are accountable to their communities and to their constituents in a different way and have a different level of support, even to make their priorities clear. And so we really encourage organizations, public health departments, and other institutions to think about leveraging those networks and supporting them also to be part of these processes. Thanks, Nana. So in light of
all the barriers that we discussed, many of them could also be looked at through the lens or the framework of economic injustice. So one of our major recommendations is that we implement interventions that improve the fundamental economic conditions of women's lives in general, and that will help women living with HIV. So we want to integrate services designed to provide a pathway out of poverty for women with HIV and into HIV care settings. So that also means, examining eligibility requirements for public programs and access ways that women living with HIV actually access their care, so that staying in care doesn't mean staying in poverty, just to stay in care. We also want to foster linkages and cross-training and collaboration with job readiness training and vocational rehabilitation for women living with HIV, so that they have the skills necessary to enter into the workforce. And so those types of interventions could also include micro-enterprise projects and building proficiency around financial management and budgeting and banking and other life skills. Also, we need to facilitate and institute computer and internet literacy and training for women living with HIV, and eliminate structural barriers to employment, including hiring practices that discriminate against people with criminal records and felony convictions.
So our next recommendation is really thinking about the quality of HIV care provided. And, I think also here there's room for even what we talked about in the last slide. So the quality of HIV care has been, very traditionally sort of siloed into this permanent service delivery model, where people with HIV are sort of forced into, if they weren't already poor and then get HIV, then you basically are forced to become poor in order to access essential services, as I think Ebony spoke to really well earlier. And that's because of restrictions on programs around income eligibility for medication access, for housing access, and other things like that. And so we really are looking at transforming a system to be responsive today. Part of what we need to be thinking about is how do we really leverage these systems that have been created, such as the Ryan White care system, to truly heal people and transform the fundamental conditions of their lives. And so that includes, thinking about how specifically in Ryan White type settings we might provide vocational rehab services, pathways out of poverty. And it also includes thinking about really healing people and providing whole wellness services. So specifically thinking about mental health services, the role of trauma-informed care as a priority for women living with HIV and other communities impacted by HIV. Trauma-informed primary care is a model that has been proposed. Trauma-informed care in general is and trauma-informed responses are a model that have been moving forward in a lot of different settings, from education to healthcare to actually even the criminal justice system. And so there are a lot of opportunities for us to learn from some of those best practices and think about how to integrate some of them so that care and community-based settings providing services to women living with HIV can become spaces where people actually heal rather than just getting medication, rather than just getting treated. So it is possible. Sort of the underlying premise of this is that it is possible to heal from PTSD, to reduce symptoms of post-traumatic stress disorder. It is possible to reduce symptoms of depression. And it is possible to improve the quality of life of people living with HIV in a way that's not just about viral suppression, right? So I think the Well Project webinar that happened yesterday really spoke to an important issue. In light of the fact that you can be virally suppressed and still depressed. You can be virally suppressed and still, coping through substance use and addiction or isolation or deciding not to show up to a medical appointment because don't feel like you can deal with somebody touching you today. So there are lots of ways in which we can think about transforming our care delivery system so that it's really a healing space. And we think that should be a priority. And in addition to that, sexual and reproductive health care and rights, in the era of treatment as prevention, we really have a huge opportunity to expand, uphold, uplift, and affirm sexuality of people living with HIV. The right for people with HIV to be sexual, to make choices about families, about having families, not having families, spacing children. And it is a travesty and a huge violation of human rights that this information has not even gotten to the communities who need it. So the fact that we still, almost 5 years after the results from HPTN 052 are seeing that nearly 40% of women living with HIV who are engaged in care, who are very well informed about their own health care, who are able to name all the medications they're taking, because we asked them that as well, and they were able to tell us exactly what they're taking. Some of them are taking 5 or 10 different medications. They know exactly what they're taking, but no provider had told them that if they were virally suppressed, they were less likely to transmit. What is behind that? That's just that is something really broken in the system. That is something really broken in thinking about how providers are or are not maybe being trained to be up with the current science. Maybe there's some embedded stigma around sexuality and reproductive rights of people living with HIV there. So this is some stuff that we really need to be thinking about addressing. We also are seeing a huge decline, not an increase, unfortunately, in the amount of peer-based services, support groups that are available to people living with HIV. There's a dismantling of the community-based infrastructure that folks have worked very hard to build over the last 30-plus years. And that is not something that we need to go away. That is something that we actually need to support and invest in and expand availability of. And those are relatively low-cost interventions that we have to maintain and keep as a priority. Because a purely medical model is never going to be enough for addressing HIV. And then as folks are living with a different sets of comorbidities and managing these multiple, sort of complex medication, healthcare treatment, toxicity of long-term meds, all of that, there also needs to be some treatment literacy available to folks accessing care to really, kind of go over priorities. And we heard that clearly from the women in the sample who said that they would really like case managers and social workers and other healthcare providers to help them more with figuring out treatment adherence plans.
Great. And so Nana was just speaking some from that about supportive services. And in the Right and White program, there's an allocation of funding for supportive services, facilitative services that can help women living with HIV remain in treatment and get around some of the structural barriers to care. So one of our major recommendations here is that we invest more in the supportive and facilitative services and reduce structural barriers to care to improve medical transportation access. So we saw over and over again in our sample that transportation, housing, and other barriers that related to economic insecurity served as major barriers to remaining in care and juggling the care and responsibilities women living with HIV were managing with their families. So we would recommend that we improve the services that women are receiving, and this can be something that's done through the Right and White program as we look towards reauthorization and making those services available to women regardless of their age. So women living with HIV are caring for their families and have these responsibilities. Programs that offer child care should have those available at healthcare sites, at clinics, and in supportive services or where they're seeking mental health services, regardless of reproductive age. Additionally, we advocate that we lift the ADAP monthly medication restriction, as we see that over and over again that transportation was the main barrier to receiving care. This could serve, only being able to access a monthly supply of medication can serve as a major barrier to women across geographic regions. Also, being able to make clinic hours more accessible, so extending clinic hours or pharmacy hours where women can, go to fill a prescription, if they are working in a job that does not allow them to go to the clinic at a particular time or go to the pharmacy at a particular time. This could also serve as a barrier to even maintaining employment. So we don't want accessing care to serve as a barrier to maintaining employment and as a barrier to achieving economic justice. And additionally, removing the barrier of, access by expanding mobile phone-based telemedicine delivery. So that could be that could have huge impact for women in more rural settings as far as accessing comprehensive care. And so finally, we need to address stigma. We need to address stigma, including institutionalized stigma in the form of HIV criminalization. We need to end HIV exceptionalism in the law. We need to eliminate laws that criminalize or otherwise target people living with HIV simply on the basis of their status. And there is a movement going on to reform these laws across the country right now. We also need to implement interventions that have been shown to reduce stigma, including internalized stigma. So, and this should be done in provider settings, but everywhere at each entry point along the healthcare continuum. So that's not only just providers, but that's case managers or even the people that women see at the front desk of a clinic should have these types of interventions introduced into those practices. And then additionally, just training providers, making sure that they are giving affirming and non-stigmatizing and non-judgmental care and services to women living with HIV in all the services that they seek. So with that, we're going to go ahead and open up for...
All attendees are muted and may unmute themselves by pressing *6.
As you just heard, we're opening up the floor for questions, discussion, comments. We'd love to hear from you all. Your lines are still muted. You can unmute yourself by pressing *6. We just ask that if you unmute yourself, you then go back on mute just to reduce background noise again. We'd also love to hear any comments or questions on the chat box. Questions and comments can be directed at any of the presenters, and then we also have a lot of the other community-based researchers on the webinar as well, who may be able to address some of the questions. *6 to unmute your line.
Hello, this is Eva Milhouse. How are you?
Hi, Eva. How are you?
I'm fine. Did you mention in your report, or somebody mentioned that there was a research going on for employment or underemployment for women?
Yes. So I would recommend that you look at some of the incredible work being put out by the National Working Positive Coalition that has actually done a bunch of data collection looking at how people with HIV have been kind of impacted by employment and non-employment and rates of folks living with HIV who have had to leave employment related to their health, diagnosis, or requirements around income eligibility. The website is workingpositive.net, and you can...
I'm sorry, could you repeat that? Working what? You said working?
Workingpositive.net. I just put it in the chat box for you.
Okay, thank you.
And
a lot of information there about recommendations that they're making to increase access to employment services as well for people living with HIV, because it's a very nuanced. It needs to be a really nuanced approach. Not everybody is prepared to just return to full-time work. There need to be ways in which we think through getting off disability and what that might look like in a way that doesn't penalize you and leave you off disability for a long time if someone realizes they are not, that working full-time isn't going to work for them or things like that. So it's a great question. I see another question.
Thank you.
Yeah, thank you for the question. Barbara, I see your question. Since CBOs working with women not located in clinics seem to be more focused on service delivery, is their funding going to be dedicated towards us? I think I'm thinking that your question, Barbara, is around the important role of community-based organizations. And we definitely agree that community-based organizations are critical and should be resourced as part of our response. There's also a question about the slides being available. We will have the slides available, and the recording of the webinar will be available as well afterwards. Again, if folks have questions, star 6 to unmute your line. Oh, there's a question about clarifying the ADAP monthly medication restriction in the chat box. Ernita, do you want to speak to that? Okay. So somebody asked about clarifying the ADAP monthly medication restriction. What we were referring to there is that if you're on ADAP, you can only fill 1 month of prescriptions at a time, usually. And there's a very small window of time in which you're actually permitted to do that. It's like 3 days or something. I know that I've had a problem myself when I was on ADAP. If you go too early to fill your prescriptions, if you're going to be traveling or something like that, and you need to fill your prescriptions, say, a week early, ADAP won't actually approve it. And so you've already, gone all the way to the pharmacy, maybe taken off work to do that or done whatever else you had to do. Then you can't get your meds refilled, and then you're out of luck if you're not going to be in town or available to get to the pharmacy at the window of time that ADAP is able to fill it. So it really can be a big barrier in terms of cost, transportation, and a whole lot of other things. And so I think one of the points we really wanted to bring out in the report is that a lot of the structural barriers we see are not disconnected from each other. So like income, being poor is not different than having a lack of transportation. Those are very integrated with each other. We also found that a lot of women who told us they missed medical appointments due to transportation, sometimes they said it was because they were too sick to go. And so, navigating public transit is really different when you're not feeling well. Getting on a few different buses to go across town and get to an appointment is really different than getting in your car to go to a medical appointment when you're not feeling well. So we just wanted to really highlight that a lot of these barriers intersect with each other. Oh, Liz, I see that you're saying Illinois has a different setup for ADAP. That's great. I'm glad to hear that. I hope that it's better.
Can I just throw in really quickly, this is more on the subject of cars? Because it's been my experience, not that I have a car, but watching other people try and utilize low-income people having automobiles. It is extremely expensive for a lot of people just to pay for gas. And then in metropolitan areas, having to park the car and pay for that, and having that additional cost paying for insurance, paying for repairs. A lot of times, and we do have a barrier around the fact that even the kind of transportation that's paid for by the government is usually public transportation. And so people that do own or need to use cars can't even get that paid for through the government. So transportation is an issue, I think, a serious issue, either way, whether you're using public transportation or whether you have a car.
Mm-hmm. Yeah, that's a great point. And by the way, the transportation issues we saw, and if you look at the report, you'll see that they didn't differ for folks in rural and urban areas. So a lot of times, we hear that transportation is a barrier for people accessing care in rural parts of the country. It's not only in rural parts of the country. It's a very big issue in cities, especially as gentrification is happening. People are getting displaced further and further away from services. And so that's a sort of emerging high priority issue.
I have a question.
Okay, so Anna had a question about, Anna Forbes is asking about what would it take politically to push ONAP, that's the Office of National AIDS Policy, to require involvement of local PLHIV networks in decision-making bodies that make policy and allocate Ryan White Care Act and other public funding. That's a great question. I don't know if folks want to weigh in on the chat box with that. I would say, one thing I would just say in response is that the guidance for community planning actually is coming from HRSA and CDC. So I think that it is important to push and target ONAP, but it's as important to hold these other federal agencies that are actually writing the guidance and the RFPs accountable. And we'd love to hear from folks who have any thoughts about that. What would it take to move, to make it a priority that local PLHIV networks are involved in these kind of decision-making processes? While folks are thinking about that, I also see lots of comments about the importance of funding for community-based organizations and women-focused organizations. And I think we couldn't agree with you more. That is critically important and needs to be built into the next version of Ryan White legislation, maintained as a priority. We can't just have a medicalized response.
Hello, this is Lapina Reed. I want to apologize that I wasn't able to get off of mute earlier. I want to say happy National Women and Girls HIV Awareness Day, and it's just been a full day of testing, and I just got out of one site and on my way to another event. That's just how it is on days like this. But it was kind of surreal that one of the first agencies that I was with at today, that Janet and I held one of our first labs, and we saw many of the women that participated. And like myself, who as a long-term survivor also participated in the survey, I want to applaud PWN and all others that were involved with the community-based participatory survey, and hopefully looking forward to what the future has to come with all the research and information that we found. So it was a great report, and I have to get to my next appointment. So thank you all.
Thanks so much, Gina. Yeah, we're really glad you were able to join, and sorry about the mute glitch earlier. But it's great that we got to hear from you. I think we have time for maybe... Yeah, thank you. Time for maybe one more question or comment. If anyone has one, *6 again to unmute. And Anna's question is still on the table, and I guess I would just, I would say that if folks want to strategize around that, I know that we would definitely love to strategize around your question, Anna. Follow up to this.
Hi, Hello?
Yeah, we can hear you. Go ahead.
Okay. Hi, this is Tania Cork in the Bay Area. And I do have a question. Is there any, like, what are the plans for the funding for the mental health? Because everything that I'm hearing in the report was so awesome. But what I'm hearing in every avenue where we're finding the barriers for us women living with HIV, it all just comes back to mental health. Everything is surrounded by mental health. When someone says that they're not feeling well, if they're on their medication, most of the time it's not, a sickness as far as like, a headache or a stomach ache or it's more mental health, like depression. Depression is, one of the main reasons someone can't leave the house and get to their doctor's appointments. It's, one of the biggest issues that we're having. But there's hardly any funding for us to be able to go out and get those resources. I know therapists right now that have been turned away from community centers because they have private practices. So they're not allowed to work within community centers, community-based organizations that, have services for us women living with HIV because they have, private practices. So, I'm just trying to figure out what are the plans for the funding for mental health regarding women with HIV, and what is the plan to make sure, now that we know that this is something very real, and if we could get those things met first, then everything else as far as poverty, all those things are linked into mental health, because if you're not feeling well mentally, then you're not, even regardless if you go get the job, you're not going to be able to maintain it because your mental health is not together. You can't focus in college if your mental health is not together. You can't take care of your family, well, if your mental health is not together. You can't raise healthy children if your mental health is not together because they model everything that you do. So all of these things, to me, boil down to mental health. And I just really would like to know what it is that, I can do, or all of us can do to make sure that these things are I think this is the main priority, is mental health.
Well, yeah, I think, Tania, you said it really well. Thank you for flagging that. And there's a lot of work to do. One of the things I would say is that there's been an increased focus by SAMHSA, which is the Substance Abuse and Mental Health Services Administration, on looking at the intersections of mental health, substance use, and HIV, and also looking at how we can create some systems that are really trauma-informed. And so I think one of the things that as advocates we can push for at the local, state, and federal level is more of these sort of like collaborative funding opportunities, and ask, because there are different kinds of funding streams. It doesn't all have to be done in the HIV realm, right? So how can mental health resources be better allocated to target and serve people living with HIV at the local, state, and federal level? Like RFPs, requests for proposals that might come out that are specifically written to prioritize and serve people living with HIV. That's one thing I would put on the table. I think there are a lot more. And I invite folks to also, weigh in with other thoughts, either on the chat box or over the phone. But thank you for raising that.
Thank you. Thank you.
Yeah, thank you. So we are about close to time, and I do want to let you know that we're going to be hosting a Twitter chat in about 30 minutes that's co-sponsored by PWN, Greater Than AIDS, and the Well Project, where we'll be really continuing this conversation. That's starting in about 30 minutes on Twitter. We invite you all to be part of it. The hashtags are NWGHHAAD, National Women and Girl HIV/AIDS Awareness Day, and hashtag PWN Speaks to follow the chat on Twitter. And I think some of these issues around strategy to apply pressure and also what advocates can do can be very much continued there. So I want to invite you to do that. And then I do want to also let you know that, we can put the link in here, that we're going to post the full report link in the chat box for you right now. In the chat box, we're going to put the link for the full report so that you can access it. We encourage you to read it. There's also a 2-page kind of executive summary teaser report that you can download and print off and make copies of that's a little, kind of easier to take and carry around with you. And we hope that you will get it out to all the different Women and Girls HIV/AIDS Awareness Day events that you're going to today and over the coming period of time. And we encourage everyone to use this in any way that's useful to you and to follow up with us if you have any questions at all. And so in conclusion, I really wanted to let you know that this project absolutely would not have been possible without a whole lot of people. And there's one person in particular I need to thank, and that is Jenny Smith-Camejo, our awesome communications director, who created all these beautiful graphics you see in the report and laid it out so that it looks so beautiful. All the graphics you saw on the slide set today, those were done by Jenny. And it really, I think helps us present the data, a lot of detailed data in a way that is accessible, comprehensive. And of course, our fabulous research team and a lot of other folks who helped make this possible. And a special thank you to our funders as well. We can't do this work without investment from funders, as we all know very well. And so funders who believe in projects that are led by communities most impacted and who aren't afraid to support advocacy are our allies, and we need them. And so we're very thankful to them. And so with that, I want to just thank you all. Thank our fabulous team of presenters, Arnita, Ebony, Lauren, Janet, Lapina, and all of the researchers who are part of this process. And we look forward to being in touch with you as we strategize for this. This is a long-term haul, y'all. So we are giving you this data early and now because we know that it's going to be a battle for the next couple of years to figure out the future of the Ryan White program and other programs serving people living with HIV. And we need to keep our eye on the prize. Ongoing implementation of the National HIV/AIDS Strategy is something we need to watch in the next administration. We have to keep monitoring what is going on and holding folks accountable to some of these issues and generating new data and more data. And so we give this to all of you. We thank you for all of your support and have a great rest of your National Women and Girls HIV/AIDS Awareness Day. Thank you for all you do. We appreciate you.